Greetings and welcome to today's webinar discussion titled How Oncologists Can Control Costs at the Point of Care, hosted by Amplity Health and sponsored by Cardinal Health. Throughout today's webinar, please feel free to submit your questions through the Q&A option on your Zoom screen. At the end of the webinar, or at the end of the program, the speakers will address the questions received during the Q&A session. It is now my pleasure to introduce Ajit Chajara, Chief Scientific Officer at Hematology Oncology Associates of CMY and Senior Medical Consultant at Cardinal Health, to start the session.
Great, and thank you for this opportunity. And I would like to thank all of our participants for taking a little time this morning or during their lunch hour to join us today. So with that, let's move on to the next slide. And what we want to discuss today is how oncologists can control costs at the point of care. Each of you in your practices have faced and are facing and will unfortunately perhaps continue to face the rising cost of care. And what we want to address in the next hour or so is, are there ways around it specific to oncology? And the next slide. So it is my pleasure to welcome my panelists today. As James mentioned, my name is Ajit Chajara, and I serve as the Chief Scientific Officer at HOA-CNY, which is a large community-based oncology practice. I also serve as a Senior Medical Consultant at Cardinal Health. And it's my pleasure to have Tanya Perk, Stephanie Mayfield, and Cathy Ube with me today. So maybe a little round of introductions, perhaps starting with Tanya.
Thank you. I'm Tanya Park, lead innovation for Cardinal Health in our specialty division. So really focused on how technology can help practices through value-based care and also aid patients. Thanks. Stephanie?
Great. Stephanie?
Hi, my name is Stephanie Mayfield, and I'm a pharmacist and practice consultant with Cardinal Health. I've been there for 5 years now and help to assist our oncology practices with financials, formulary decisions, pretty much anything drug related.
Great, and moving on to Cathy Ube. Cathy?
Good morning, everyone. My name is Cathy Ube. I'm with Pontchartrain Cancer Center in Louisiana. We are a community oncology practice in that area. Good morning.
Great. Thank you all for joining. And for the sake of this webinar, we're all going to address each other by our first names. So I welcome you. And let's look at the agenda for our webinar today. So what we hope to do is talk about the financial impact of cancer care on patients, the barriers to managing costs at the point of care, how treatment decisions drive episode costs, and then what are the ways in which physicians can better manage patient financial toxicity? And we certainly hope to save some time for Q&A. So like James said, please do send your questions to us throughout the presentation. In terms of, we can move on to the next slide. I think for all of you attendees, there is no doubt in my mind that you're well aware of the rising cost of cancer care in the United States. So these are data from the Cancer Action Network. And back in 2015, the cancer-related healthcare spending was $183 billion. This number is, as you can see in this graph, expected to grow to, it was $200 billion in 2020, and then $222 in 25, and grow to another 34% to $245 by 2030. These high costs are paid by many people, as you all know. These are individual cancer patients and their families, employers, insurance companies, and taxpayers. Next slide, please. So in terms of financial toxicity, what we want to talk about is the actual patient out-of-pocket costs. And what is remarkable is that these patient out-of-pocket costs can really vary dramatically. Here's just an example of a patient, adult patient with lymphoma. And look at the wide variation in terms of out-of-pocket costs depending on who the payer is. So as you can see in the graphs below, there are the ACA compliant or comprehensive plans, which include Medicare, comes in about 8,600. Then there's the small employer with high deductible health plan, which pushes it over to almost 11,000. If Brian's employed by a large employer plan, this is our fictitious patient, it's about 6,500. And if it's in the individual marketplace plan, that's about 13,000. But look at the short-term limited duration plan. So, the point of this graph is that there's remarkable variation. And insurance coverage is critical. In each of these scenarios, patients pay considerable sum of out-of-pocket for their care, but would have paid significantly higher amounts if they had not had the insurance coverage. The type of insurance a person with cancer has is an important factor in how much they will pay out of pocket is the key takeaway. And out-of-pocket limits help protect patients with cancer. Patients with cancer are super utilizers of their insurance benefits, and each patient in these scenarios who have an out-of-pocket limit have reached their maximum rather quickly. Once the maximum is reached, the patients do not have to pay cost sharing for in-network or covered services, as you're all aware. So this is an important protection for many privately insured patients. Another statistic to share on our next slide is that unfortunately, 2/3 of the bankruptcies in the United States are related to medical issues, like being unable to pay for medical expenses or medical related work loss. Another dramatic statistic is that people diagnosed with cancer are 2.5 times more likely to declare bankruptcy. And those who do so face an 80% higher risk of dying than those who don't declare bankruptcy. So all in all, what we're saying is that healthcare costs are burgeoning and the burden is being felt on patients and families across this country. It can drive them to bankruptcy, and really bankruptcy becomes a risk factor for, it is associated with high risk of death. So quite dramatic there. Again, talking about not only the cost of cancer related to treatment and management, but also there are a lot of indirect costs of cancer as shown on the next slide. As all of you know from your daily work and engagement, there is transportation, there's food insecurity, there are lodging expenses. There's the concern about loss of wages, and again, caregiving expenses. So there's just so much more. And these are not even covered or addressed by payer coverage. So because of the costs, because of these high costs, many people with cancer and those who survive cancer will experience financial hardship, including problems paying bills, depletion of their savings, delaying or skipping the needed medical care, and potential bankruptcy, like we talked about. These costs and hardships do not impact all cancer patients equally. There are certain factors that make a patient more likely to experience financial hardship. So what are the characteristics of patients who are more likely to suffer from financial toxicity or face financial hardship? And that profile really is a younger patient, a person of color, someone who's less educated, and have lower income. So unfortunately, again, the underprivileged are again having to bear the brunt of the financial toxicity to a greater extent. And we talk a lot about there's been remarkable progress, and we're all thankful for the science and the research that has brought us here. We know that actually, for the first time in decades, cancer-related mortality in the United States is improving. That means more survivors, which is great. But even survivorship care has costs. It's important to know that even when a person's completed their surgery, radiation, chemotherapy, immunotherapy, or targeted therapy, whatever it may be, the costs of care do not end necessarily. And many survivors will have to deal with cancer symptoms and side effects of treatment, not only for months and years, and sometimes these are lifelong. So anyone that has a brush or run-in with cancer, unfortunately, is looking at a high cost of healthcare during and even after the cancer diagnosis and treatment are completed. And just to sort of round off this, because this is not something, what I've been talking about is not new to you, and you know, you all see this every day. But there are various types of financial toxicity. If we can go to the next slide. So we've talked about, you know, the actual material toxicity, which includes things like out-of-pocket expenses, household bills, missed work, reduced or lost income, medical debt or bankruptcy. But there's also an immense psychological burden. You know, patients fighting cancer and facing financial toxicity have feelings of distress due to the cost of cancer care. They have concerns about the income meeting necessary expenses. We've heard the, you know, medication or food dilemma before. There are behavioral impacts where patients may take less or may skip medications, or they may delay or even avoid postpone medical care due to the cost involved. Basically, the cost burden is all around. And while we're grateful for the progress in cancer, you know, there need to be ways and methods for addressing financial toxicity, and that really is what we want to talk about today. So I think I've been talking for a while, so this is a perfect time to bring in our panelists today. And get some discussion going. So, well, let's start with perhaps Cathy. Cathy, welcome. And can you start off by telling us a little about your organization and your role? And I'll probably ask the same of Tanya. So, but Cathy first.
All right. So I'm the CEO of Pontchartrain Cancer Center. We're a 2-location community oncology practice in Louisiana. So we have multi-specialty infusion, clinical trials, physician dispensing, pharmacy, and a hot lab for radiopharmaceuticals. We are the only community oncology practice in both of our locations. And just to give you a sense of flavor for that population, one of the practices sits in the most affluent parish in our state. And then just 30 minutes to our west, our other practice is in the 5th most rural parish in the state. So we really see a gamut of population there.
Yeah, so much dichotomy, and just, you know, all technically under one roof of a sort of a unified practice. So in your world or down in Louisiana, and especially with the contrast of the two practice sites, so how do you define financial toxicity?
Well, you know, and that's something that we talked about on our practice call, because financial toxicity to the 4 of us is going to be very different than our patient population. And I'll fall on my sword with this story, but many years ago, when we were starting to address financial toxicity, when we do our treatment plan visit financial breakdown for our patients, we had, you know, we would start looking for financial assistance if the out-of-pocket to the patient per treatment was $50. That sounded reasonable to us, but it wasn't reasonable to our patients. So then we had to turn around and lower that threshold. And really, we're down to about $10 to $15 a treatment. And, you know, if their out-of-pocket is that, or even a little bit over, we are looking for, you know, pharma assistance, foundation assistance, you know, for all of our patients. But in addition to that, we do a financial screener with all of our new patients at that visit, because we are trying to enroll them in programs addressing all of those social determinants of health, food, lodging, you know, any of those insecurities from the get-go. And we have an entire workflow and a team kind of built around those things, where we're notifying the providers and kind of pulling those things through and having regular touch points with those patients. And in addition, let's not forget the families, because, you know, very rarely, we're not treating patients in isolation anymore.
Sure.
We are really having to address, you know, the entire kind of family unit, especially when you have caregivers who are taking care of that, you know, that cancer patient, taking time off from work and addressing those needs. You know, it's become a larger process. but a better process because we are addressing it much more holistically, which we are seeing has driven adherence, patient satisfaction, and several other things that have really it's more work for us, but it's turned out with better outcomes.
Wow, that's a lot, Kathy. And a couple of points resonated with me, and I'll turn to Tanya in a moment, but while you have this mic, so to speak. So one thing you mentioned that I think resonates certainly with my practice is having that team and the workflow to identify these. You also mentioned social determinants of health. So I certainly want you to do maybe a little bit of a deeper dive in terms of what that workflow looks like, or what is it that you're really uncovering. And then, as a technology guru, then I want to turn to Tanya and see, what her vision of this is.
Okay, so, from a true nuts and bolts workflow perspective, it's a financial screener that we do at all of our new patient visits. And then that will then, and it's scored by the medical assistants. So then very quickly, that'll be given to the provider before they go into the room for that visit. And there's just that brief discussion about, we see you filled this out. And how do you feel about one of our financial counselors reaching out to you? And then we do have a one-pager around those services that we offer, and we give it to the patient at that time. And then it just kind of goes to that financial team who already handles benefits, authorizations, but then they really are kind of becoming, because we can't employ social workers in our organization. We don't have the bandwidth for it. So this is our workaround. And then, so then it's financial. We're talking to church groups and handling it that way. We've done a partnership with the food bank in our area where once we get.
A lot of sort of, in a way, homegrown networking and support, sort of identifying and then trying to come up with solutions which are, germane or specific to your community, literally. So no, hats off. But it all starts with sort of identifying these at-risk patients in a way, Great, thank you for that, sort of view from the trenches, let's say. And then Tanya, you are, you have such a varied experience in technology. And so you tell me, what comes to your mind when we're talking about financial toxicity. And I mean, you kind of create and develop systems to assist practices, while you and Stephanie, to kind of aid them in also providing timely care without the barriers of the financial implications potentially. So if you want to comment on FinTox, we're just going to call it financial toxicity, FinTox, and also social determinants, as Kathy was pointing out.
Yeah, I think it goes to how can we create that financial transparency and make sure we're having the right conversations with patients. And that's part of the consideration. Unfortunately, it would be fantastic if, all we had to think about were those clinical parameters around the patients, but that's where that underlying social determinants of health really comes into, and financial insecurity is such a big part of that. And, cancer care is just essentially imposing this extra cost that is adding to the burden on the patient and their families from a financial perspective. So obviously very significant, but I think having that earlier conversation and having the financial piece part of those treatment decisions is important here, mainly so we can also help, right? So having those assistance programs and getting the patient earlier versus later, right? Where it becomes stressful and actually starts to impact outcomes, having those social supports that really assist the patient throughout their treatment journey, knowing about it up front is critical. And then the other side of social determinants, which we see really from a population health lens and where we can leverage AI is helping manage costs where adverse events can be avoided for that patient population. So if patients are at high risk for an admission, which can drastically increase out-of-pocket costs all at once, those are things where if we can identify those patients earlier, potentially see them in practice versus having that adverse event occur in a really expensive event. Those have impact on when the patient has to pay. I think, it's these out-of-pocket costs happen. It's also, when does the patient hit those out-of-pocket costs, and how do we manage that through the year, right, as they're on their treatment path?
Wonderful. So, certainly we heard the process on the front office and at Cathy's practice. And then, from you, I think it's really interesting to hear how some automation can help with that identification or using augmented intelligence, identifying those patients so that we can maybe intervene in a timely manner, thereby preventing the high cost bad outcomes that we all fear and the patients fear and we all want to avoid. No, that's very helpful. That's great. And so who wants to take this? Can someone elaborate, let's say, on the role of the insurance payers, and how that may play out in terms of patients' out-of-pocket expenses? Cathy, you want to take a stab at that?
Sure. So it is all about the payers, because we have to get that authorization and benefit design on each individual patient and their payer. So, from a different lens in addressing cost, that's where biosimilars really have come into play in our organization. We were very early adopters, and I kind of tell the story. It's like, buying a car. So the deductible is just that. It's not really going to change, but we can do things as an organization, usage of biosimilars and really, patient education and stuff. So we can stretch out over a period of time, a longer period of time, how long that patient has to pay into that deductible. So when we're looking at, financial toxicity, being able to stretch that out kind of takes the sting out of things in such more of an immediate way. So we are looking at less of a true, hit to the patient in regards to all of those social determinants of health.
Great. No, great comments. So in terms of, so I know you brought up biosimilars, Stephanie, should I pull you in in terms of your view on biosimilars and, the utilization and role of biosimilars has been growing, but where do you see it now? Like, how far have we come? Have we sort of achieved our intended savings, if you will, or do we have a long ways to go? What is your quick take? And then we'll talk some more about it later this hour.
Yeah, unfortunately, I think we just pretty much started. There's a lot of other biosimilars that are in the pipeline over the next 5 to 8 years. Unfortunately, again, for us and for the practices and the patients, it's just going to get many more options, more confusing, but financially, I think it's definitely going to be helpful for the patients, but it's just going to be a lot of work on the practices that we see today. I just think it's even going to be compounded even more, but we'll just have to see, but yeah.
Great. So your take is we're just getting started on our biosimilar journey, and you're right. I mean, there's just so many biologic agents that are going to be potentially, the blockbusters drugs of today are immunotherapy in the in the foreseeable future, so there's just a lot of other things coming down the pike as far as biosimilars are concerned. Tanya, what are your comments as technology and sort of behind the scenes person in terms of developing tools for practices to deal with this deluge of dealing with the payers, identifying the patient ahead of time, estimating what the cost to the patient is going to be. How can technology assist with that? Because practices are overwhelmed for sure, but anything that we can do to ease that pain, I think is welcome.
Yeah, obviously technology exists to see what those patient costs are from an insurance perspective, and that's coming in. We want to make sure we try to pull that in also to the treatment decision. So, does this patient have a high deductible plan? What is that out-of-pocket max? Because those vary widely. in terms of how much they may spend. And that's an important piece to pull in there. The other aspect where I think technology can help, you alluded to the fact that these practices are going to have to manage all these biosimilars, and that gets really complicated, especially if you have regimen libraries that have a regimen with every different biosimilar in there.
Right.
So how can we kind of automate that substitution, right, where practices can default to a biosimilar that's going to get managed in those regimens automatically. I think there are a lot of technology tools that can make this coming adoption of biosimilars a lot easier on the practice. We'll still have coverage issues and variability among payers in terms of the policies and what they want practices to use for their patients. So that's kind of coming in the future, right? Is how do we really combine how practices can easily default their biosimilar, but then look at, what is that payer actually going to support for those patients?
Right. So hearing a lot of different themes. So if I were to ask you, Cathy, what are the types of resources that exist today that can help patients and providers better understand the financial implications of treatment? I go into a room, I talk to a patient and family, I decide on regimen X, and then of course I have to run off and to see the next patient and hoping that the team's got it all squared away, or I'll even put in my flow sheet and the patient's supposed to start chemo immunotherapy in 2 weeks. But then how is it that you, as the CEO of a large practice, what are the resources that you use today to aid patients and families?
Sure. So we address all of these, cost and social determinants of health at the second visit. So we talked about the first visit where we do that screener, and then we bring them back prior to the initiation of therapy for a treatment education visit. So we're going over all the drugs, side effects. I built this 98-page binder that really just kind of addresses everything, including port care, nadir, and all of that. But part of that is also the financial discussion. So for every single patient prior to the initiation of therapy, whether it be, chemo, GI, because we are a multi-specialty infusion center, we have already done that, prior auth and benefit analysis. And we have it's a good old fashioned spreadsheet that line items all the drugs, the administration costs, and then the out-of-pocket to the patient. But we also use that as an opportunity to talk about, the financial assistance that we've been able to get for the patient. And so we kind of show them very black and white. That's also when we talk about all of the social programs that we've been able to find for them. So we address it all in that visit prior to therapy. So there's no sticker shock per se, because you really want to do your best to alleviate as many burdens as you can before you get started on that. Does that make sense?
Yes. So, the spreadsheets got me a little worried, but I guess, but you're absolutely right. That's kind of where we are today, or where we've been. And, we're sort of trying to move to the next level, if you will, in terms of simplifying some of the tasks, or at least automating, not throwing the AI word around every time. But so, Tanya, any comments on that? And then we can talk about and also, if you want to address, what are the barriers that you see in the current scenario in terms of managing the cost at points of care?
Yeah, that's that spreadsheet view is I think very common for, I think getting that data to the patient and having those conversations is happening, but it's happening in, different tools with different practices have different ways of doing that, right? So where I want to see us go is how can we make that even easier, right? So that we can pull that data in with the clinical considerations and really say, okay, here's a financial piece of this treatment that we can discuss with the patient. Here's also these clinical factors. And then how do we compare these to pick the right treatment at the point, you know, for that patient based on that patient's goals of treatment outcomes. So I think it all comes into having the right conversations with that patient and having a piece of that be all the clinical considerations and what that patient's goals are, but also the financial piece here.
And so I think in my mind, there's like two parts to this, right? I mean, we're fortunate, like the drug pipeline and offerings have exploded. Our options have really expanded dramatically, especially in the last 3 to 5 years. Of course, the last 2.5 years, we've been dealing with the pandemic. So I think, and I was just using myself as an example. I'm sure there are better informed physicians out there, but you know, one of the things that I think about is with more and more treatment options, and therefore also not just clinically, like you were saying, Tanya, but also more financial impact or greater need to assess the financial impact of these multiple newer therapies. You know, what can the physicians do to stay well informed, not only about these, well, clinically, but also what impact they have on the patient and the family's finances. And that's one piece. And then, of course, you know, what can the patient do? But let's talk about, you know, what can oncologists today do? And I just don't mean oncologists. I mean oncologists and our APPs, our PAs and NPs. You know, we're working shoulder to shoulder with oncologists in the clinic every day. Who wants to take a stab at that? Cathy, let me go to you.
Sure. Well, I think some of that is shared decision making from the get-go at that new patient visit. You know, what are the goals of therapy? And, you know, how can we help you get there? It is a complicated discussion. And, you know, Ajit, I know you didn't go to medical school to have financial discussions impact your patient. And I know that's because I see it in your face. I mean, it's very challenging for oncologists, you know, to understand that we're moving a little more from health care to health business, and none of us are thrilled about it. But it is the reality of what we see. And, you know, then there's that discussion of, you know, do you treat the patient regardless of cost? And then what do you do on the back end? And you saddle them with this, you know, bill that, you know, we saw in earlier slides, then sends the family into bankruptcy. Right. So, you know, perhaps we've cured the cancer or done our job on that from that perspective, but then what's the cost?
Absolutely. And Stephanie, let me pull you in because, you know, I mean, you work for Cardinal Health, but you're obviously connected with the patient care aspect of it. So for clinicians, you know, what do you think oncologists and oncology clinicians should be doing? You know, shared decision making certainly, but also clinically, like what else can they be thinking of? I know you brought up biosimilars before, so there's that. Also, we have like multiple in-class options now, like we have, you know, multiple PD-1, PD-L1 agents, you know, perhaps more similar than dissimilar, and similarly, you know, in other drug classes too. So any thoughts on that in terms of overcoming the barriers from a provider perspective?
Yeah, I mean, unfortunately, like Cathy said, you know, it's really becoming a business now. So, you know, yes, as long as everything is clinically effective, side effect profiles are the same, it does come down to the financials. So one of the things that I actually do as part of my job with helping the practices is at the beginning of every quarter, and actually even a couple of weeks before, like you know, the new ASPs just came out today. So we're going to start looking starting today with the next couple of weeks and see, okay, are there going to be, you know, where there's some major changes in Medicare reimbursement? And if so, then we have to start seeing, are the pharmaceutical companies coming out with new contracts to kind of counteract that. So either we can stay with the current treatments that we're doing, or if they don't, you know, do we have to switch to a different, you know, biosimilar brand, or again, a different drug, you know, based on the changes that are just happening. So literally starting today until usually the middle of the beginning of the quarter, because that's when a lot of contract changes are happening too, it's a constant looking at every single class, every single drug, to really see, you know, is it viable for the practice? Is it viable for the patients? Right. So the next 4 or 5 weeks is really what has to be done every single quarter. And again, it's a lot of work. And again, that's where we come in to be able to help out with that so that the practices don't have to do all the legwork. They don't have to do all the manual calculations and spreadsheets and stuff like that, because we want you to take care of patients. You can't take 5 weeks off to just figure out financials. There's still patient care. So it's a lot of work.
No, very true, Stephanie. I think those are really valid comments. So at every large practice, oncology practice, as the director of pharmacy or the pharmacist, as you know, is so critical to the functioning. I know we talk about shared decision making typically in the context of, well, the provider and the patient, but really is like provider, the pharmacy team, and the patient, because it all has to gel together if we're going to actually impact the cost to the patient. I mean, the cost of the system is high, but we're really trying to minimize FinTax and save the cost, the out-of-pocket cost to the patient. So is there anything then that patients can do to help manage costs? Like what type of conversation should they be having with their team, and what can they be asking for? Cathy?
Well, they need to be very transparent with us, because there's nothing worse than, especially when you have a patient on an oral therapy, you bring them back in a month later and, how's that going? And well, I've been cutting my pills in half, or I'm skipping a week, so they can help, what they think is afford their therapy, but then that has other costs to it. So I think it's really just having those conversations up front, social determinants of health, financial toxicity, not just the patient, but that entire family ecosystem, and then developing workflows and metrics that have regular touch points with those patients and that family to make sure that we're doing, we're still meeting the patient where they are at every, point down the road. But it is complicated, and
Right.
it does take a lot of people within the organization.
Absolutely. And, so I think some of this for our listeners, you may think like, oh yeah, I live this every day. But I think part of the purpose is also to share with you as a group that, yes, these are true issues, true barriers that every practice is facing, every provider is facing, every patient is facing, essentially, and to a greater or lesser extent, as we said at the beginning. And what it really boils down to, so we're talking about many different things. So what can the providers do? Maybe they can choose a better in-class drug. Maybe they can choose a biosimilar. What Cathy's talking about, patients being transparent. What we're talking about is using technology to identify at-risk patients. What Stephanie's talking about is, keeping that pharmacy team, the core, engaged in a way so that we're aware of what changes might be coming down the pike. And is there a simple way to affect that? So what it boils down to is, how treatment decisions can ultimately impact the cost of care, every episode of cost of care. So in that regard, Tanya, let me ask you for your comment in terms of, why do you think it's important for physicians to have this type of information at that point of care, and how can that be available to them seamlessly or easily?
And I think it comes down to everything we talked about, right? Financial toxicity has a negative impact on outcomes for your patient. So if you're not considering that aspect of the care, it can have exactly the wrong effect of all the clinical work that's going into trying to do the right thing to cure cancer, or at least treat it. That is part of the equation here. So having that be part of your treatment decision, pulling that data in, particularly the patient cost aspect of it, just helps inform the decision, and also the conversations. These are hard conversations. Having that initial diagnosis is a hard conversation, and then that patient side, right? It's hard for patients to say, I need help, right? That's hard. No one wants to admit I can't afford this, right? That's really tough. But if we're able to have those conversations, then we can try to get help, right? Cathy, your practice has done so much to figure out, okay, well, what kind of assistance can we turn to help that patient actually afford treatment? And then it also goes into practices that have navigators that can check in, and that could be part of the conversation as well as they go through care.
But Ajit, it's also about bringing in your entire team. So physicians, APPs, nurses, because even some of this patient education that we do up front, it needs to be pulled through at every touch point. So, we launched this program called Call Us First, because, rather than showing up in the ED because, you have uncontrolled nausea and vomiting, call us first. We can bring you in, so how do we address some of those things? Call us first. Maybe we bring you in for some anti-nausea, additional hydration, but we're avoiding those ED visits. And then also, having a robust oral adherence program to address oral therapy. We do have that in our workflows with our nurses as well. And it's again, 2 days after they start, then a week after that, because there's nothing worse than finding out a month into it that they're not adherent.
Right. Now, those are absolutely, very valid points, Cathy. And I think these are things that we see just about, every day, every week in our practice. I really liked your Call Us First initiative because, again, that's the whole idea. I mean, whether you think of any value-based care initiative, be it OCM, be it COPI, which is the ASCO's quality initiative. I mean, the whole premise is to promote high value care and to minimize low value care. So, and again, nationally, about half the practices participate in OCM. So, if nothing else, I think practices have the opportunity to learn what does ideal high value care look like, and so it is a learning process almost, so that whenever the next iteration comes by, hopefully everyone's more acclimated and just better, more well-versed with the whole concept.
Yeah.
Great. So any other comment, Cathy, there? Or else I have some questions for Stephanie, maybe, in her other comments? I know I go this way, that way, because that's how
okay.
I slide up on my screen. So, so Stephanie, turning to you, thinking about your role as a practice consultant, what other types of benefits exist to help optimize a practice? Again, optimize it for the practice, for the clinicians, and of course for the patients, which are the center of our efforts.
Yeah, so again, looking at everything on a quarterly basis, and like I said, one of the things that we do is we provide this information to our customers. We also do have some tools in Cardinal that they can look at themselves. We have a regimen analyzer where, again, you can do a lot of the same stuff and be able to compare drugs together, look at it with different payers if need be. But definitely you can look at Medicare as soon as new Medicare numbers are out with cost, rebates, all that information is there at the clinician's fingertips, at the financial people's financial counselors, because we also have patient financials in there too. So you can look at what's good for the practice. Also, is it good for the patient? And then there's even information about patient assistance programs and things like that, all in this one tool together. So, and again, anyone can get on it at the practice and be able to use that on their own. But then they also have us to be able to assist if they have questions further than that, or need more in-depth information.
So that's the regimen analyzer. And I know you talked about biosimilars before, and you said we're just about getting started, but any comments perhaps from Cathy in terms of what are the barriers to adoption of biosimilars for you? I know Tanya spoke about sort of the EMR integration. If you have like 6 different biosimilars, how many order sets are you going to build? But do you encounter other sort of issues with biosimilars at your practice?
I think the biggest barrier for better biosimilar adoption is the payers, because a lot of payers pick different biosimilars. So for any given drug class, we might be stocking 2 or 3 of them, and that's a challenge. For us, it's not a space issue, but for from a financial perspective, if a nurse gives the unauthorized biosimilar to the wrong patient. So we're not talking safety, but it's financial risk, because then we run a high likelihood of, not getting paid. So that is the biggest thing. And that's what we see in oncology. Being a multi-specialty infusion center, we've seen adoption within biosimilars for the other specialties to be fairly low. And, COA did a really large data project around this last year. And what we saw was it is lower in the other specialties because very often they're not the infusing provider. So they're writing a prescription to us for the drug that they're comfortable with, and they've known for years and they know it works. And so then because we don't have interchangeability on those drugs, so then what do? And it's, the physicians really don't want to have to call that prescribing provider and say, hey, do you mind if we give X, and, Inflectra or whatever. And so that's what we've seen. And, we kind of hit on biosimilars earlier. We are in its infancy in the US. It's still a very young market. And, we're getting ready to see ophthalmology kick in this summer. That'll be very interesting to watch. And then, we all saw the news the other day of Humira and the biosims really starting to come down the pipe for that. So this is going to be a fascinating market to watch. But if we can help foster a positive and healthy biosim environment, I mean, the cost savings that we've seen to patients, to us and to the overall healthcare system really is encouraging.
Right. Thanks for those comments. And I agree that, biosimilars are certainly going to be on the climb, both the use and the potential indications. So I know we're in our last quarter of the hour. So let me go to Tanya, ask you a couple of questions. So Tanya, from your perspective, two questions. Number one, where can, where else can patients find support? Are there other resources that should be considered? So that's one question, so patient-centered. And then the other is, what about the practices? What's for them next? Practices are overwhelmed. I mean, of course, and this is not even with the pandemic. I mean, of course, that's thrown a curveball in everybody's life and everybody's practice. But aside from that, they're just overwhelmed keeping up. So what tools or solutions do you have in your magic bag, or what suggestions do you have for patients and for practices?
I think there are a lot of support programs there for patients with manufacturers or foundations or other charitable organizations that are out there. I think that's a good match. Unfortunately, we even see patients turning to things like Kickstarter campaigns where they try to involve people to fund treatment. It's just the reality of where we're at. I think as much as practices do to help that financial navigation for the patient, that's a really good thing. The other area that's really interesting is this idea of kind of value-based contracts on the pharmaceutical side, where you're kind of paying for that performance or value of those new drugs that are coming to market and they're really expensive. I think that's an interesting aspect of potential future care. We're not there yet, but just having an idea of having value as part of that equation is very interesting. And then on the practice side, right, I think it's really how do we pull these things together, right, and create a set of value-based tools that really change how we deliver care, because it's not a fee-for-service world anymore. So how do we help manage that transition and create those right tools, whether it's that population lens across your practice of what patients need the most help, whether it's adding financial information at the point of care, whether it's, tracking costs, right? How do we even know how much cost happens over an episode, right? All of those things are challenging.
So I think, you break it down well, because there's an issue of the cost, like programs like OCM Rewarded, lower cost, care overall, but we all know that drug costs and regimen costs is such a big component of that whole process. So there's that piece. And then we've been talking about a lot of other things in terms of bringing, utilizing AI to identify at-risk patients for bad outcomes. Again, just sort of having a workflow or an integrated value-based care solution kit, like you said. And I know we have a slide that you wanted to go over, so we can bring that up if we want to speak to that. But I think that in of itself is the critical piece. Having both the support for the decision making in the exam room, and then also the overarching sort of workflow. So if you want to speak to that.
Yeah, sure. So for Cardinal to really lead our Navista TS suite of solutions around value-based care. And as we started thinking of this picture, right, what are those technologies that we really need as we make that transition from fee-for-service healthcare, where, more costs get added on to really a value-based lens on care, both value to the patient, value to the practice, et cetera. So today we've really been talking about how do we manage for this financial toxicity aspect and make that visible in making the treatment decision. So that's really where Decision Path plays, that we're introducing. So with our HR partner, CareMD, we're really trying to, pull in what is that cost to the patient. So you can see that during that treatment decision making. How do you compare across treatments that may have similar outcomes for that patient? And then how do you really deal with this burden of managing biosimilars so we can pull in lower cost options for the patient? Remember, it's not when, we're going to reach out of pocket, but how do we manage that financial spread across time for the patients?
This is really important. I want to highlight that because this is something Stephanie's been talking about, in terms of and Cathy's been talking about. So we don't want to compromise clinical efficacy yet come up with the the most suitable, albeit lowest cost alternative. And I assume this has the capability of being payer specific, because again, that will vary as well.
That will come into this as part of our future roadmap, of course. But first piece was to say, let's add transparency to the financial aspect of care, so we can have and enable the right conversations between physicians and their patients. And then Decision Path, really, if you bring the next slide up, is really part of, technology as we look at it, just one of those components, right? So how do we manage that population of our patients and make sure we're trying to avoid adverse events that lead to cost for those patients at greatest risk? And then how do we pull in the right treatment decision, including the financial transparency aspect of it? How do we track cost of care once we're in an episode and look at where we are at? And then the other aspects of this are really, what's our foundation that we build this all on? Can we integrate across everything? And we haven't even talked about trials and that part of patients, but really that's an important consideration as well, is how do we make sure, patients have access to trials in our community and optimize for that piece as well before we even get into what treatment are they on. That has to be a part of it.
Yeah, no, I think you bring up a valid point. So it's multiple. So what we currently lack is this sort of overarching tool that will guide the clinical team, not only with the clinical piece, but with all of also the financial piece. And the point you raised about clinical trial participation is a critical one, because, well, of course, not only is it good clinical care, as a lifelong trialist, I can attest to that, but also it can have many other sort of benefits, allows access to, newer therapies, and especially for patients who may otherwise, suffer from a high financial burden that they have to contribute to or have an out-of-pocket cost for the standard of care medication. If they can be easily matched to an appropriate trial, then that can be a great saving for them, and not only beside cutting edge care and state-of-the-art treatment. So other questions, thoughts? I'm looking to see in our chat if we have any questions from our listeners.
I think there is that in QA, Ajit. I think there's a set of questions, maybe a couple around, and the diagnostic portion for Cathy around.
Yeah, I see that. So
That's
can you
really-
elaborate, Kathy, on on the patient screener tool you mentioned earlier, and how
Sure.
you've seen that impact financial toxicity?
Okay, so someone asked if I can share that screening tool. Sure. Yeah, I'm
Yeah.
happy to do that. It's like literally that big, so not hard to implement. Happy to share it. Oh man, diagnostic testing. That's a complicated one. But um, we do contact the payer, and we do a prior auth on all of our NGS and diagnostic testing. And so we don't have one vendor that we use. We use several. And some payers have ones that they prefer, but also we're looking at that financial assistance through those particular vendors and what they offer, and then those recommendations for the patient. I wish it were different, but NGS testing has become it's a little more complicated, because sometimes, for certain vendors, it's well, we won't bill the patient. And then we have run up against that as a problem or so before. So sometimes we're trying to pick, what do we really need to be able to, to get us where we need to be? And it's not always going to have all the bells and whistles. Ajit, how do you guys, handle that within your practice?
Sorry, say that again, Kathy.
So how do you
Just trying
guys, does your practice, just have one vendor that you guys use for all your NGS, or how do you guys handle that?
Oh my God, yes. So that is like the battle of the titans.
Yeah.
It just goes on and on and on, because people have providers have preferences. And quite honestly, at our practice, so that people are wedded to a particular vendor that may remain unnamed, but now we have other competitors that may offer a broader, wider service. And most importantly, very critical, I think, in the context of NGS is the access to trial. So if I get a very unusual mutation, but then, I don't want a laundry list of things or whatever. I mean, if the patient can be seamlessly matched to a trial, and I have the opportunity to open that trial for that one patient, without having to keep bunches of trials open, hoping that our patient will show up. So, after the fact, then that is what is most ideal for me. But anyway, so I'm kind of trying to work on that within our practice, and trying to get people together. And, I think what it may boil down to is having more than one option, at least, having at least two to satisfy most people, because some people feel very strongly about one or the other. But of course, it's a technology nightmare for our, for our IT team, because, then they have to do all this integration. It's a nightmare for our lab folks, because then they have to remember, and they have to be more order sets and what have you. So it's everyday, issues. So having better EMR functionality would help if the EMR was, more easily integrable with other vendors. So that is another. I see Tanya nodding, because, we always turn to technology. We're all living in this universe. We're so interconnected. The clinician cannot function with all of the other team members, without the pharmacy, without IT, without lab, and of course, without our financial folks. So, one other thing. First, let me ask for our listeners, don't go away, or our viewers, don't go away yet. You see this poll popping up on your screen. Please take a moment to answer it. We do have actually a couple more questions come in, and I will read them out in just a minute, so you don't leave. But I do want to say thank you to Value-Based Cancer Care for hosting this discussion. But before you all leave, one other question that I am hoping our panelists can answer. Cathy, question for you. Can you share some examples of how your practice, like a case of where you actually help manage costs, or a case study, or, best case practice?
Okay, I'm reading it. Well, I think we are managing costs for all of our patients by the workflows that we've designed, by doing that, that treatment breakdown from a financial perspective at the very beginning. And I feel Stephanie's pain because we do look at our contracts and our fee schedules, you know, every single quarter. So yes, this afternoon, Stephanie, you'll probably feel my vibe because yeah, the new contracts are starting to come in and we have to start looking at those. So that's how we, by doing those financial breakdowns per patient, that helps us manage our costs quite a bit by oral adherence programs, by finding ways through, those social determinants of health to keep our patients on therapy and keep them adherent, reducing phone calls to the practice, reducing ED visits, all of those things. Is it, do I have a case study per se? I mean, no, because it's just something we do every day. Now, biosimilars, yes, because I'm the one who did the data project for COA. So that was, I'm sitting on data for 2.7 million administrations. So I can talk to you about, access to care. I can talk to you about changes in Medicare allowable when the biosims came to market. Now that I can do, but, sure. I mean, maybe we do some sort of case study around this because it would be really interesting.
Thank you, Cathy. And one last comment I'll make before we close this. I see a question from Robert. To what extent do you think the ASP mechanism contributes to the increasing drug costs? So I think at least my comment to that would be, and that is why we have OCM, and that is why we're going to have OCF. And the whole idea, as Tanya, I think, pointed out, or Cathy mentioned at the beginning, moving away from fee-for-service and moving to a more value-based care model, where, that's the whole premise of value-based care in terms of it. In programs like OCM, we're incentivizing practices to learn good ways of managing patients at a lower cost. And if you do a good job, then you get rewarded. And I think that is something, whether we like it or not, as practices, as clinicians, we'll all have to learn that. But if anyone else has any comments on that, I'll take one last comment and then we'll move on. Cathy, did you have a comment? Okay. All right. Well, what can I say? I really want to thank all of our listeners, everyone that dialed in. Like I said, thanks to Value-Based Cancer Care for hosting this discussion, and special thanks to Cathy, Tanya, and Stephanie for spending time with us on this topic today. And then for our viewers, if you'd like to learn more about technology solutions for value-based care from Cardinal Health that Tanya shared somewhat with you, please visit this URL here and fill out the form on the page, and then you'll be contacted shortly for a demo or for further information. And again, have a great rest of your day, and thank you for joining us. So long.